All right. Hello, everyone. Welcome to a Tuesday VMR. These are usually the Ravi and team VMRs, and I'm so excited to have the opportunity to co-discuss alongside the incredible Ravi. So really excited for today, and we get to hear a great case from Ethan. Maybe we can hear from the voices who are helping to make this session happen. So maybe we'll start with you, Julia, who's doing teaching points. Do you want to unmute, kind of share how you're doing and maybe an update with the VMR community?
Sure, Maddie. Thanks for the beautiful introduction as always. I'm very excited for the case. Today, I'm really lucky because the weather is so nice and it just started to get back into my marathon training. So, um, yeah, that was fun.
That is amazing. Between you and Deborah, so many incredible runners here. My gosh, that is so awesome. Are you scheduled, Julia, to do a marathon, or is that something more in the distant future?
Oh no, I did my first one last year, and there's one end of May in Stockholm. So
My
there's
God.
there's a goal. I'm
Amazing,
excited.
amazing. So exciting. Well, best of luck to you and to Deborah, who are both training. And Lyra, who's doing teaching points. Lyra, do you want to unmute and maybe share an update, something that you did today with the community?
Hi everyone. So sorry, I can sound a little congested because I've been dealing with the cold since Saturday. So this is like the first day that I'm able to breathe through my nose. So I'm really
Oh,
happy about that.
well, that is a great thing to be able to breathe through your nose. I also have had just like a low level kind of congestion in my throat for so long. So I feel you. It can be rough to not be able to breathe through your nose, but I'm so glad it's it's getting better. Ethan, what about you? Thank you so much for presenting a case. How are you doing?
Yeah, I'm doing great as well. Interesting, here the weather is getting cold. Can't believe it's March and it's getting cold, but yeah, nothing too exciting today. I was planning to go for a run as well, but it's too cold, so I decided not to do that probably tomorrow. Yeah,
Yeah.
and excited to share another case with you all.
Thank you so much. Yeah, I'm really excited to hear from your case. And Robbie, how are you doing? I know you gave us a little bit of an update before we started the session, but you want to share an update with everyone who's tuned in?
Oh, sure. Happy to be here. Happy to be discussing with Madalena for it's been quite a time, a long time. I think the last case we discussed was something along the lines of weakness. So, and then yesterday I was reminiscing with the SLS team about boot camp. Remember those days?
Yes. Oh my gosh. Boot camp.
How, it's interesting that the journey um, from that time, and you were a med student and now intern, and the tremendous growth that you've gone through. It's just incredible. So very happy to be here and then to intersect at various points throughout the last few years, and to see your growth in the world of VMR. So just absolutely amazing.
Thank you, Robbie. Well, you have been just kind of a pillar of support and inspiration for all of CP Solver's VMR. And I challenge those who are tuning in to find the boot camp YouTube videos and amidst all of the thousand VMRs on YouTube. But those are really fun. I feel like that was one of the first things I did when joining VMR, doing those boot camp sessions on problem representation, and those are really fun. But Robbie, you have just been just such an amazing kind of support and inspiration for all of CP Solver. So we are so grateful to have you. And I'm so excited to co-discuss with you. It has been a little while. I think we have tackled a few neuro cases together, so we'll see what Ethan has up his sleeve. All right, shall we jump into it? Go ahead, Ethan.
Yeah, so today we have seven aliquots, and the final aliquot will reveal the final diagnosis. So today we have a 36-year-old male presented with progressive lower limb weakness and numbness for 2 weeks. So this patient came to the neurology clinic, and he said that for the past 2 weeks, he suffered from progressive lower limb weakness and numbness. And after the symptoms developed 3 days later, he also has hoarseness and dysphagia,
Mm.
and becoming more severe in the recent 2 to 3 days before a presentation to the clinic. And he also had lost 6 kilograms of weight for the past few weeks. And on his dysphagia, he reported that he couldn't swallow solid food that is too dry, but he can tolerate soft diets. And he reported no dyspnea or any respiratory symptoms, no urinary incontinence or retentions, and normal bowel movements. And that's the end of first aliquot.
Wow, Ethan, what a start. And Ravi, it seems like we have some neuro adjacent case to discuss. So looking forward to this. But Ethan, yeah, what a first aliquot. So, we're getting a few, there are multiple kind of chief concerns to tackle here. We're hearing about a young man with progressive lower limb, both weakness and numbness. So we're hearing both a sensory and a motor concern. Seems like that's been happening for 2 weeks. And then we're also hearing this concern more of dysphagia and hoarseness. So in terms of kind of where to start from here, I think whenever you have a neurologic concern, I think it's really helpful just to anchor ourselves in the equation that Aaron Berkowitz has taught us, which is localization times time course. So I think what we can try to do here is see how much progress we can make on the localization. And, to start with weakness and numbness, so as I mentioned, that's both a motor and a sensory concern. But if we just start with kind of the weakness, so we know that for us to be able to move our muscles, to be able to walk, that depends on the kind of corticospinal motor tract. So we can think of a lesion anywhere from the cortex to the upper motor neuron, in the spinal cord, to the lower motor neuron, the peripheral nerves, neuromuscular junction, and muscle. So when someone has weakness, there can be a lesion anywhere along that pathway. And then if we think of numbness, we can kind of think of the reverse. So what sensory nerves do is they take kind of sensory input from our environment. It travels along the sensory nerves, which are peripheral nerves, go into the spinal cord to our sensory cortex. So if we think, what does the overlap of both a motor issue and a sensory issue, like how can we make progress on the localization when you have both of those? Well, it's probably not just a muscle or a neuromuscular junction issue, because then how would you have the sensory component? So I think when someone has weakness and numbness, I am thinking more of this could be a peripheral nerve issue, this could be a spinal cord issue, or there could be kind of multiple lesions in the cortex leading to this. So that's what I'm thinking for the weakness and numbness together, either peripheral nerve, spinal cord, or cortex. I think what's interesting is that we have the hoarseness and dysphagia. So now I'm wondering if there are deficits in cranial nerves leading to issues with kind of hoarseness and dysphagia. So the localization is pretty tricky here. I think the last, I'm really curious to hear Ravi's thought, but the last kind of additional clue here is that it is lower limb. So I'm translating that into like leg weakness. And so it's not arms yet. And so I'm trying to think if we can make progress on the fact that it's localized just to the lower extremities. And I think this could still be a peripheral nerve issue. I think Ethan gave us really helpful pertinent negatives that it sounds like there has not been any bowel or bladder changes, and you would expect that if there were a spinal cord lesion. So right now I'm tentatively, this could localize to peripheral nerves and maybe also cranial nerves given the hoarseness and dysphagia. But I'll pause there. And Ravi, curious what you are making of this and if what your thoughts are on localization.
Oh, I just want to say, Madalena, you just did a wonderful job. For those that are joining, I would just say if you've matched into residency, you go out there, tell people, come to VMR, because this will just help you along the way in your internship how to tackle a case. And that's just exhibited by what Madeline has just done, just so elaborately gone through neuroanatomy and then related it to this patient complaint. This is a very difficult beginning of a case if you think about it. And the reasons for this can be so many. And sometimes if you read through book chapters, everything sort of siloed into different conditions. But what you've wonderfully done is put everything together: upper motor neuron, lower motor neuron, muscular, vascular, and so on. So try to sort of explore the whole landscape of what could be causing such a presentation. And I'm very worried about this patient, 36-year-old. What would a 36-year-old manifest with, especially coming into the clinic and having like, hey, doc, I can't move my legs, and I'm also having sensory impairment as well. So just to augment your wonderful discussion there, I'm going to move out of the realm of the nervous system and then look at what else could be causing such a situation. We're so lucky on VMR to have so many great and rich cases presented to us, and then we learn so many vital new things that other things could actually manifest with something like this. And I think it's sort of like familiar. We had such a presentation recently. So one thing that comes to mind is maybe digestive problems. What if there's a nutritional deficiency, and that can manifest with maybe some vitamin deficiency or something like that? Subacute combined degeneration of the posterior columns, maybe leading to nerve damage and other symptoms that you may get, lack of vibratory sensation and 2-point discrimination and so on. How about last week I discussed with, I think it was Yasmin, we had a patient with lower limb weakness as well, pulselessness and so on. And it was neuropathy, diabetic neuropathy plus vasculopathy, right? So that could be caused by many different sort of conditions, vasculitides. It also could be peripheral arterial disease and so on. Then you have muscle and joint issues. Here we don't have any signature for joint involvement, but could this be an autoimmune phenomena? You got these lower extremity problems, which are a reflection of a upper process, which could be central or peripheral. So this dysphagia and hoarseness is very concerning. And this kind of has a pattern. First, I was thinking, type 1 thinking, is this like a GBS? Is this going from bottom to top? The weight loss, I would assume, I'm not going to give it too much weight because, yeah, weight loss, give it weight, no pun intended, but this is probably due to this dysphagia and so on. So I can sort of move that to the back and not really consider it, unless if I want to bring it to the front and center and think it's maybe due to inflammation. So we're thinking about what could cause such a severe presentation, maybe an inflammatory process, maybe a paraneoplastic process. Although malignancies in a 36-year-old rare, but can occur. So right now, there's multiple things going on. It's just not the legs, it's also the muscles of deglutition. And I have to start wondering, is this primarily, like you explored, maybe the nervous system? Is this a nutritional system? Is this a downstream effect of a endocrinopathy? Could this also be nutritional? I think, yeah, nutritional, vascular, endocrinopathies, and then the nervous system. So, and then autoimmune conditions. And you have to start wondering, could this be something like a polymyositis, a muscle involving autoimmune condition? So many thoughts, but I think what will really help us is past medical history. Always have to lend some respect to the medications. Could a medication manifest with something like this? Could there be substance use disorder in a young patient? And then the exam will be vital for this, and it could actually move the needle forward in trying to decipher what exactly is going on. So if you have anything exhibiting like an upper motor neuron phenomena, that might help us make progress. Anyway, back, any other thoughts come to mind? I kind of rambled on a bit.
That was absolutely brilliant, Ravi. I really love the kind of hypothesis of nutritional deficiency. I think that'd be an interesting thing to explore. And as you said, the past medical history, I think it'll be really, I'm curious to hear from Ethan what this patient's kind of baseline has been. Like 30 young person, it sounds like this started 2 weeks ago. Like prior to 2 weeks, was he completely healthy person and this was kind of an abrupt change for him, or has this been kind of a slowly brewing process? So I completely agree with you. I think those are really, really great points.
That is a great thought. I love that. In any history taking that we do, I always tend to, I forgot to mention it, but this is like gold. If you had X 2 weeks ago, how were you a month ago?
Yeah.
Were you having any inkling of this before this? Is this something that has been ramping up, or was this a sudden onset of an event? Was there some sort of infectious process prior to this? So yeah, that's a very good question. And I see internship, you're getting more expert in these kind of in deciphering a history. So kudos to you for that.
Thank you. All right, Ethan, back to you. It's a really interesting case so far.
Amazing discussion. So on his past medical history, he has no any chronic disease, and he was discharged 2 weeks ago from another hospital for acute cholecystitis. And on his physical exam, on his vitals, he was febrile. Blood pressure was 135/83, and a heart rate of 112. Cardiac exams and pulmonary exams and abdominal exams are all normal. And we have a full neuro exam, which showed GCS was full. We did a JOMEC for cortical function, which was intact. And we did a fundoscopy in the clinic, which was normal and showed no papilledema or any abnormalities. And on cranial nerve 2, the visual field is normal. The visual acuity was normal as well. Cranial 3, 4, and 6, the extraocular movements were normal. The pupil were symmetric and reactive to light bilaterally. And on cranial nerve 5, the facial sensation was symmetric to pinprick. And on cranial 7, there was no facial palsy noted. On cranial nerve 8, there was no hearing impairment. And on cranial nerve 9 and 10, there's slurred speech, hoarseness, and dysphagia noted. And on cranial nerve 11, testing his SCM and trapezius, there's a normal neck turnings and shoulder elevations. And on cranial nerve 12, there's no deviation on tongue. And we did a motor exam, which shows upper limb was 5 of 5 proximally and distally. And in his lower limbs, there's 1 to 2 out of 5 bilaterally. And distal is weaker than proximal. And he cannot walk on heel, but is able to walk on toe. And on deep tendon reflex, upper limb were all normal, so 2+ in bilateral elbow, and negative in bilateral knee reflex. And on his sensation test, showed plantar numbness and no other abnormalities in his dermatomes. And testing his cerebellar function, there's no dysmetria. And because of his lower limb extremity, tandem guides and Romborg test was not able to perform. And that's the end of second analysis.
All right, Ravi, do you want me to take this one first? Do you want to take this one first?
Go ahead, see what you can think. Interesting exam so far.
Yeah, so this is very interesting. Well, just to kind of start off where Ravi and I left off, we were interested about this patient's medical history, and does not seem too rich. We heard from Ethan that it sounds like he had a cholecystectomy, if I heard that correctly. Was that right, Ethan? He had like his gallbladder was removed?
Yeah.
Thank you. So, I'm not putting too much weight into that, but I think I'm just kind of keeping that in the back of my mind to see if that is relevant. It sounds like that was, I'm sorry, I think that was a few weeks before this presentation, if I heard that correctly. So keeping that in the back of my mind, that could this surgery have triggered or unmasked whatever presentation this currently is. Now, if we focus on, again, for any like neuro concern, localization is really, I think, what's most helpful here. So if we try to localize this, what I'm hearing from the exam is that most of the cranial nerves were intact, except for 9 and 10, leading to this slurred speech, hoarseness, and dysphagia. So I think we were concerned initially from the first aliquot, could this dysphagia, slurred speech represent a cranial nerve abnormality? And I think I am explaining that at this time by like a cranial neuropathy. And we're seeing the other parts of the physical exam, the motor and sensory, pretty much like translated to what Ethan gave us on the history. One question, so the deep tendon reflexes, those were the reflexes all normal? I'm sorry, Ethan, do you mind just clarifying that?
Yeah, normal in upper extremity, but negative in lower extremity. So knee reflex are absent bilaterally.
Oh, so they're absent or
Yeah,
diminished? Absent.
in the knee, yeah.
Okay, thank you so much. So that's really helpful because reflexes can help us localize to kind of upper versus lower motor neurons. So diminished reflexes generally point to a lower motor neuron. So I think what I'm seeing here is that in the lower extremity, we have diminished reflexes, we have objective weakness and sensory deficits. So I think I would be localizing this to the peripheral nerve, given that we have diminished reflexes, we have motor and sensory deficits. And if we bunch this in with the cranial neuropathies, those cranial nerves are also peripheral nerves. I'm wondering if we can localize this to like a peripheral nervous system issue. And I'm wondering if it's the same process that's affecting, like, there's some process that's affecting peripheral nerves leading to this motor and sensory deficits in the lower extremities and also the cranial neuropathies. And so I'm wondering here if we think about what can happen to peripheral nerves, I think I would bucket this as a polyneuropathy because we've seen that multiple nerves are affected. And generally, whenever you have like a peripheral neuropathy, it's helpful just to clarify, is this a mononeuropathy, one nerve affected, mononeuropathy, multiplex, multiple individual nerves affected at different times, or a polyneuropathy where you have kind of several nerves involved in the peripheral nervous system. So I think I'm framing this as a polyneuropathy of the peripheral nervous system. And if we think about what can happen to the peripheral nervous system, you can have demyelinating disease, you can have kind of, as Ravi said, nutritional deficiencies affecting the peripheral nervous system. I think, Guillain-Barré's, what Ravi said is an interesting hypothesis here. Like, could the surgery have triggered a Guillain-Barré syndrome? I believe in Guillain-Barré, I forget if it's either like diminished or absent reflexes. That's something on the differential too. I've talked a lot, so Ravi, maybe I'll pass to you and hear what you're thinking at this point.
Well, Maddie, yeah, every time we discuss, it's always a neurologic
I know.
case. But you're doing a wonderful job. I can see the growth from the last time we discussed and the time before that, because the last two cases were neurology cases. So this is how you learn. And I think discussing the same cases again and again don't help us to learn and also expand our knowledge. So I think you're on the right path. I think there's, if we just focus in on the leg, there's a lot of signal in the leg. So this with the sensation, if you think about sensation and the plantar aspect is numb, you have to start worrying about maybe I think the sensations delivered by the tibial nerve. And then the patient cannot walk on their heels. So was the patient dragging their feet? Are they having foot drop, Ethan?
Yeah, so basically foot drops, so patient walks on toes, yeah.
Okay, so there was a reason why this is familiar. There was a case on Thursday. And if you want to listen to Thursday, Ravi did a good walkthrough of foot drop. And in that case, I'm not going to give away what the diagnosis was, but it was a very, very, very rich case where we explore the whole spectrum of neurological diseases involving the lower extremity. So with this foot drop, you have to worry about peroneal nerve injury, but then the downstream and upstream combination, you can't help but think of a multi-system condition. You know, a couple of things that come to mind too was ALS came to mind, multiple sclerosis. We talked about GBS. When you have many different nerves, you have inflammation, you have to start worrying about things like amyloidosis, multiple myeloma, poems comes to mind. So there's so many kind of multi-system conditions. But you know, before we jump into the landscape of rare disorders, what could be causing something like this? So foot drop probably is just, I mean, most commonly caused by peroneal nerve injury, but could there be other conditions? I think Yasmin had mentioned last week, we talked about Charcot-Marie-Tooth disease. That could be a condition, although we're not getting on the exam, we're not getting the various features of Charcot-Marie-Tooth disease, where you have the inverted bottle configuration of the lower extremity as well. What else? Muscular dystrophy could also manifest with something like this, or just a simple peripheral neuropathy, like a peroneal nerve injury that Ravi had discussed last week. Again, the multi-system neurological conditions, can't help but think about them. There's no past medical history of any endocrinopathy. Diabetes could manifest with something like that. Alcoholism could cause nutritional deficiencies and could manifest with neuropathy, but nerve injury, no trauma, no compression. And so we have to think about, absolutely, like Maddie, you had mentioned, nerve injury, which could be degenerative, myelin degeneration, or axonal injury. So there's two kind of different injuries that you can have with a peripheral neuropathy. Which one at this point, I'm not sure, but it would be worthwhile doing EMG nerve conduction velocities to see, which in that case last week were done. And it was helpful in trying to figure out what was going on with that patient. But at this point, I don't have a specific diagnosis to plant my flagpole on or in. But I think there's a lot of various hypotheses at the point. Maybe taking a look at the labs to see if there's any signal of inflammation. Maybe that could point us in the right direction. But wonderful case so far. I think definitely rich with a neurological exam and all the possible causes of foot drop and also impaired sensation. So you have two different nerves that could be involved. I think in the plantar tibial nerve, and then I don't remember what it dissects into, and then also foot drop as well with peroneal nerve involvement or injury. Back to you, Ethan.
Yeah, great discussions. So on his initial labs, white cells are 8.5 with a normal differentials. Hemoglobin was 12.8 with a MCV of 102 and 0.9, and platelets of 235. Coax are normal. And BUN was 14.6, creatinine was 0.65, sodium was 143, potassium was 4. His AST was 675, ALT was 1,456, alkaline phosphatase was 972, and GGT was 911. Bilirubin was 1.8, direct was 1.8, and total was 3.1. Albumin was 4.5, CK and B12 were normal, glucose was normal, and the ferritin of 1,982. And CRP was 1.5. So we also sent some acute viral serologies. HBs antigen was negative. Anti-HAV IgM was negative. Anti-HCV was negative. CNV, EBV, HSV, VZV were all negative. HIV was negative. Ceruloplasmin was normal, and anti-mitochondrial antibodies and anti-smooth muscle antibody was negative. We also sent abdominal ultrasound, which shows normal size of livers and normal biliary trees with borderline splenomegaly. We also did a CT of abdomen, which showed no significant enlarged lymph nodes, borderline splenomegaly as shown in abdominal ultrasounds, and unremarkable findings in liver, biliary tree, gallbladder, pancreas, and GI tracts. And all the vessels are patent. And that's the end of third aliquot.
Let me take a look at this,
Please,
Maddie.
yeah.
I've had you go the first 2 times, so let me see what we can trigger through the deciphering of the lab. So hematology, really not much there, little anemic. MCV is 102, so let's kind of put a pin in that, see if it's something that we can explore. But macrocytic anemia is not necessarily always B12, folic acid deficiency. There could be liver involvement as well. And let me see anything else that could come to mind. But yeah, I guess liver disease, chronic liver disease could also cause this as well. Chemistry-wise, what really stands out, what you see in red. So AST, ALT is elevated. ALT is more specific to the liver. So ALT is greater than AST, and ALP is elevated, and GGT is also elevated. So this points to likely a cholestatic process. The bili is elevated. Okay, direct. So yeah, bili is also elevated as well, and the ferritin is elevated. At this point, I'm not going to go into the realm of hyperferritinemia. It's not tremendously like greater than 10,000 due to conditions like histoplasmosis, adult onset still disease, and so on and so on. But I think this is a marker of inflammation. It's acute phase reactant. So there's a lot of noise in the liver. Is this secondary to the cholecystectomy a few weeks ago? So what may have happened? A stone may have lodged into the CBD with retrograde pressure on the liver, and then you can have elevated liver enzymes. ALP is elevated. Bili can be elevated. You could end up with cholangitis if there's an infection that drops into that system. So ascending cholangitis can happen. But here, the patient's not septic. The patient has residual inflammation in that region. But you know what? If this was the case, so ERCP is done, the stones are removed, a stent could be put in to allow for the material to evacuate the CBD, but everything should resolve. You'd imagine this hotbed would then cool down, but then to have persistent elevated liver enzymes, there's something going on in that area. So a very deep, very broad workup was done with all the different viral markers. Nothing was really found. Ceruloplasmin was done. Could the ferritin be a signal for hemochromatosis? At this point, we're not seeing other features of hemochromatosis, but I would expect it to be elevated. But first thought would be, could this be TAG2 and due to the cholecystectomy and what happened prior to the cholecystectomy? Because we don't know how the patient presented. Did they present with right upper quadrant pain, et cetera, acute cholecystitis, cholangitis, and so on? There have been cases where gallstones have remained in this common bile duct post-cholecystectomy. So could the patient be having any residual features of that? But there's no abdominal pain. So that hypothesis kind of would be moved to the back burner. But at this point, I'm trying to link, okay, liver, cholecystectomy, and then all these neurological sequelae of this condition. So maybe, like you had mentioned, Vale also jumped into the chat and said that maybe GBS could happen post such a procedure. Could there have been something intra-procedure, like some medication, some anesthetic that could have triggered something like this? Not sure, but definitely I would explore the operative report to see what could have happened. How was the patient procedure as well? Could there be any inkling of this back post procedure? But I'll hand the mic over to you, Maddie. See what you think.
Ravi, that was a brilliant discussion. I love how you're putting these things together, and maybe we have a lot of data, so maybe I'll try to summarize what we have right now. So the way I'm framing this case is a 36-year-old male who 2 weeks ago had a cholecystectomy, but besides that, no other known medical history. And he's coming in with 2 weeks of progressive, and I'm framing it as like a peripheral polyneuropathy, found to have, I would say, severe acute liver injury. So that's how I would frame this, like 36-year-old male who had a cholecystectomy 2 weeks ago, now coming in with progressive polyneuropathy and acute liver injury. And I think, yeah, I think now the question of the cholecystectomy, its relevance, I think I'm bringing it a little bit to the front of my mind rather than the back of my mind, given that we have the severe elevation in liver enzymes. And I think whenever I see AST and ALT in the thousands, I've seen lots of cases of kind of rhabdo that have very high, basically the AST is not specific for the liver. So I want to make sure is this coming from muscle? But I think, as you said, the ALT being more specific to the liver in the context of the cholecystectomy, I'm more inclined to think, is this coming from the liver, especially with, as you said, the alk phos and the elevated GGT. And so if you just try to focus on that and then try to integrate that with the polyneuropathy, when you have such a severe elevation of liver enzymes, I would want to check an INR just to make sure, do we need to be concerned about liver failure in this person? Because for liver failure, you would need, coagulopathy and hepatic encephalopathy ultramental status. And we do have this patient who has a severely low GCS. So I'd really want to check an INR. But then if we just think about the severe acute liver injury, you can think of issues at the level of the plumbing or the parenchyma. So that's why it was very helpful. I think I heard Ethan said that he had imaging and there was patent vessels. So I'd want to make sure there's no clot in the hepatic artery, there's no clot in the hepatic vein. And then as you said, kind of related to the plumbing of the liver, the biliary tree, could this person have acute stone disease even after this cholecystectomy leading to this? And then for the parenchyma, that's where kind of these infections come in. So viral hepatitis, HIV, CMV, EBV, and also meds, toxins, kind of supplements, in addition to more rare things like Wilson's disease. So I think to summarize here, I think we should entertain the possibility that the severe acute liver injury is not necessarily related to the polyneuropathy, but could it be? So could there be, could he have had this cholecystectomy and then there was some complication of that, like a severe, obstruction in the biliary tree? Could there have been an infection related to that? And then this infection has kind of caused a GBS-like syndrome. I think that could be one way to put this together. I'm just curious, trying to figure out what next steps to do here. Like, do you do an LP? Do we need to be concerned more about vitamin deficiencies, kind of with the elevated MCV and B12, and we've learned that kind of the serum B12 is really kind of an not very reliable test, so we could consider sending an MMA. I learned the most common cause of B12 deficiency is actually pernicious anemia, so, given the neuropathy here, would we want to say anti-intrinsic factor antibodies? So I'm a little bit lost and not entirely sure how the liver injury and neuropathy fit together, but I think there may have been a complication from the cholecystectomy leading to both of these things, but not entirely sure.
Yeah,
Any other?
Maddie, yeah, it's funny. It's almost like a seesaw. You have two problems here: this liver with a post-cholecystectomy and this neurological process. So I think if you just pivot away from the liver, just focus on the nervous issue, I think it pretty much is probably signaling GBS, right? So, and like you had mentioned earlier, this could be something that's triggered post-procedurally. And commonly if you read mix-up, right, you're in internship, you have MKSAP and you look and then they always list infections. One of the most common infections is Campylobacter jejuni. So if you're trying to relate the digestive system with GBS, I know that could cause it. Could there be an infection to trigger it? Many other infections possibly could, viral infections. Patient doesn't report any prodrome of an infection during this process or the 2 weeks in between the cholecystectomy and the presentation. But could there be antibiotics that could have been given? I mean, you could just open the lid on many different things. But I think GBS, this patient has the hallmarks from running from the lower extremities upwards, and it's usually both axonal injury, demyelination, NCV, EMG could be done. But I think a CSF will be helpful to look for the infamous albuminocytologic dissociation. I said it. Okay.
Yeah,
Sometimes I have
nice.
trouble
No, you have to say it
trying to
5 times in a row.
have trouble trying to pronounce it. And so I would look for that. And then what is going on in this liver? So very interesting. So it is almost like a seesaw. It's like you prioritize one, and the other's down, then you prioritize the other. And the other's down. So we got to focus on one of them. And it could be the liver causing this, but we need a diagnosis for the neurological abnormalities. Anything else, Maddie, before we hand the mic back to Ethan?
No, I'm so curious to learn from Ethan. Yeah. Back to you.
Yeah, amazing discussion. So actually, the patient was admitted with the clinic doctor having an impression of AIDP. So, but after admission, they saw this high elevation of liver enzymes. Then also with the broad negative study, so the team was initially don't know what's going on. So we opt for neuro examinations first. So we got an MRI of brain, which shows mildly dilated ventricles, but no hydronephrosis, and small hyperintensities in bilateral coronal radiata, suggesting small vessel disease or demyelinations. And a DWI, so the restriction studies showed no restriction of water diffusions. And after contrast injections, there's no definite abnormal enhancements. And then we got a LP, which showed a normal appearance, and yellow color is yellow, with a leukocyte count of 220 and 89% of lymphocytes, a protein of 473, a sugar of 35, and Grandstem was negative, India Inc. was negative, TB-PCR was negative, VDRL and Cryptococcus antigen were both negative. AQP4 antibody was negative, and cytology was negative for malignancies. We also sent a meningitis/encephalitis panel using multiplex PCR for test for infectious etiology survey. So basically, E. coli, H. influenza, listerias, meningococcus, group B strep, group strep pneumonias, CMV, HSV 1 and 2, and enterovirus were all negative. And the only thing that was positive was HHV6. And that's the end of fourth aliquot.
All right. Thank you, Ethan. Interesting. So here, kind of the additional data that we have here were MRI indicating small vessel disease, dilation of the ventricles, and a question of demyelination. And then we see an LP here, and I am framing this as lymphocytic pleocytosis with an elevated protein, and it sounds like the HHV6 was positive on the CSF. Is that right, Ethan?
Yes.
Okay. So Ravi, maybe we can kind of go back and forth on this. I think so we have kind of acute onset polyneuropathy after cystectomy. We have severe elevation in the liver enzymes, and now we have a lymphocytic pleocytosis. Yeah, I think, with Ravi, we were kind of questioning in GBS, you'd see that albuminocytologic dissociation. But I don't believe that this LP is consistent with that, especially with the lymphocytic pleocytosis. But maybe we can go back and forth on that if you have a different opinion. I'm wondering if, the lymphocytic pleocytosis, so that can be caused by a lot of things like infectious etiologies, autoimmune etiologies, cancer. I'm wondering if I would just have to read more about if the HHV6 can explain all of this. And I'm not entirely sure. Like with HHV6, could that cause kind of severe acute liver injury? Could that be the etiology of this peripheral polyneuropathy? And I'm not entirely sure about that, but maybe I'll just prompt that question to you, Ravi. Like, do you think the HHV6 explains this?
Yeah, it's interesting. Is this a detractor, or is this the endpoint diagnosis, as we like to say? Is this what's gonna close up shop on what's going on with this patient? I'm thinking it's a detractor. Was this a PCR, or was this immunoglobulin levels, IgG,
Yeah, it's
IgG?
PCR.
PCR, okay. So, if this patient, if PCR I'm not sure about the details and intricacies. Could this have been an old infection? And there's remnants of this. Not quite sure, but if you look at the landscape, and FUO, we talked about the HHV 8, 6, causing fever more than 3 weeks in a patient without a diagnosis on their preliminary workup. More common, if I think, in kids, and it does cause that roseola emphaticum, if I remember, but I've not seen this in adults. And usually any sort of remnant of it, or PCR finding of a virus, is not a good thing. So this is where I would actually reach out for help to see if this is actually the organism of interest, or is there something else there? Other clues, there's quite a bit of leukocytes, so 89% lymphocytes. So this could also then augment our suspicion of this virus causing this. But at this point, yeah, I definitely my illness script for this and HHV6 is limited, but it's something we found. But we have to then consider, could there be another cause for this? And again, I'd be interested in doing a search to see if HHV6 can manifest with this, or is this GBS and this is a red herring? And we want to also do the EMG nerve conduction studies as well in this patient. It's also interesting that there's no, say this is an encephalitis, you get cranial nerve deficits, seizures can happen, altered mental status, fevers, maybe you get neck stiffness, Brzezinski-Koenigs, not kind of getting those flavors. We're just getting this patient coming in and he's having the weakness in an ascending manner, downstream and upstream, post-procedure. So I don't think this infection is associated with that. So yeah, less likely. And yeah, Mark had mentioned, yeah, when we went over FUO in the student VMR, the immunosuppressed patients tend to get this, or organ transplant patients tend to get this. We're not also getting that flavor unless we haven't done an HIV or checked for any sort of congenital. He's 36, so maybe there could have been an immunodeficiency that was missed before. Although you would present recurrently with infections, so if you have something like SCID, sinopulmonary infections and so on would be in the history.
All right, Ethan, we'll pass the mic back to you.
Yeah, amazing discussion. So that's exactly what we do. So we consulted infectious disease and asking them if the HHV6 positivity could explain all of this. And they suggest to give ganciclovir for treatment for suspect HHV6 encephalitis. And we also empirically give doxycycline for atypical infection coverage. And then we got a NCV and EMG. So NCV showed absent F waves in tibial and deep peroneal nerves, and absent H reflex response in bilateral tibial nerves. And EMG showed marked spontaneous activity in L5 innervated muscles and L4 paraspinal muscles. So suggesting denervation in L4 and L5. So overall, the summary of the NCV EMG is L4 to S1 bilateral lumbosacral polyradiculopathies. And we did an MRI of T-spine to L-spine, which showed multiple enhancing and round nodules at corna medullaris and cauda equinas. And we did an upper endoscopy as well because of his dysphasias. that showed esophageal candidiasis. And that's the end of fifth aliquot.
So what he just mentioned, esophageal candidiasis, you have to have an immunosuppressed state to have that, right? So oral candidiasis can happen. Just routine antibiotics can cause that. Not having good oral, I guess, care could cause something like that. But esophageal candidiasis, this we haven't had an HIV test. I would be worried about that. This could be an AIDS-defining complex. And I think also to test if the patient has had any sort of immunocompromised state, like somebody's mentioned in the chat, yeah, hypogammaglobulinemia. So testing for doing a SPEP might be helpful in this case as well. Any other ideas, Maddie?
I think that's a great point, that I think taking this esophageal candidiasis and seeing if that's a marker of an underlying immunosuppressive condition like HIV. And I think I had heard Ethan mention the HIV was negative when he was giving us some of the viral hepatitis serologies, but I would probably repeat that again.
Oh, okay. Yeah. There's a lot of data. Sometimes it escapes, but yeah.
Yeah, I would absolutely repeat that. And I think I'm curious of the localization here because, initially I was concerned about a polyneuropathy, so concerned about like peripheral nerve issue. But now that we're seeing signs on imaging of, I feel like there have been multiple indications of spinal cord, I believe. Let's see. And multiple enhancing nodules at the conus medullaris, cauda equina. Now, yeah, I'm just a little bit curious if there's also spinal cord involvement in addition to peripheral nerves as we initially thought. But I think practically at this point I would repeat an HIV. That's the only thing I can think to do right now.
Yeah, actually, that's a great point. You just focused in on something. And if you relate that to the esophageal candidiasis, there's some immunodeficiency that's happening. And I like that. Repeat the HIV. We've had numerous VMRs here where the test could be initially negative, and then once you repeat it, it could be positive. So this patient definitely has something going on in the spinal cord. Over to you, Ethan.
Yeah, amazing discussion. So we repeat the HIV and it was negative, and we did a liver biopsy which showed chronic hepatitis with focal bridging fibrosis and mild inflammatory activities. So non-specific and for any etiologies. So also we got an HTLV1 which was positive, and we got a peripheral blood smear which showed atypical lymphocytes and some teardrop cells. And that's the end of sixth aliquot. And next aliquot will reveal the diagnosis.
Oh, all right. Let's see how we can put this together. So HTLV1, I have an association of that with myelopathy. So I'm wondering if there are a few things going on here. Like, could he have HTLV1 causing a myelopathy? It's a gap in my knowledge if like HTLV1 can cause severe acute liver injury, but maybe it can, or maybe the other positive virus we had, the HHV6 it was, maybe both of those viruses are causing severe acute liver injury. And then the teardrop cells, so atypical lymphocytes and teardrop cells. So my reflex association with teardrop cells is an issue in the bone marrow, and I think you can see that in myelofibrosis. So yeah, I'm really kind of stretched to my limits here, but could HTLV1 be causing a myelopathy? Could be infiltrating or suppressing the bone marrow? Could that lead to myelofibrosis? I'm not entirely sure here, but I'm wondering if all of these symptoms are secondary to issues from HTLV1. What do you think, Ravi?
You hit the nail on the head. Yep. HTLV1, you're wonderfully associated with this. We were thinking HIV, but HTLV1 is a retrovirus, and it does the same thing like HIV. So it will infect the CD4 count or the CD4 cells and the T helper cells, and it will give you a complex like HIV. So the esophageal candidiasis HDLV1 if it's not HIV. So this patient is immunocompromised. And what's interesting is HDLV1 also can have a complex similar to like multiple sclerosis. So HDLV1 can cause leukemia, lymphoma. It can also cause neurological presentations like a multiple sclerosis, if I remember. So all of this could be, that seems to be the cause here, definitely. And you could probably explain everything by that. And not the HHV6. Maybe that's a bystander, an infection that was like partnering up. Hey, you're immunocompromised. Let me come create some diversion there. But this was in the background. This was what we call, if you watched The Wizard of Oz or Wicked, it's the wizard pulling all the strings in the background, right, behind the curtain. So wonderful, wonderful case. And let's see what Ethan has in store for the final DX.
Yeah, please teach us, Ethan.
Yeah, amazing thought. So we get a bone marrow core needle biopsy, which showed marked hypocellularity, so about 10% cellularities, and atypical lymphoid cells, and compatible with adult T-cell lymphoma leukemias. And we repeat CSF several times, and one time it showed clusters of abnormal lymphoid cells, also compatible with adult T-cell lymphoma/leukemia involving the CSF. So the final diagnosis is lymphomatous adult T-cell leukemia lymphoma with leptomeningeal spread complicated with neoplastic lumbosacral reticulopathy. We originally wanted to do an excisional biopsy of the colon medullaris lesions, but because of the anesthesia risk, so the operation was canceled. But we got this diagnosis from the biopsies. So about this adult T-cell leukemia lymphomas, it's caused by chronic infections by HTLV1, as you all mentioned, and it's often highly aggressive. But the clinical presentation could be, there's a lot of clinical variance in its presentations. So interestingly, just as Ravi mentioned, this HTLV1 like HIV infects CD4 positive cells, but in HTLV1 infection, CD4 count is not reliable for the immunocomplements like HIV infection, because when HTLV1 infected the T cells, it could cause monoclonal expansions of the CD4 cells. So actually, sometimes the CD4 count even could be elevated instead of suppressed. So there are a lot of clinical variants in this adult T-cell leukemia lymphomas. The most common form is acute form, which presents with significant circulating malignant cells. So the white count will be significantly elevated, even higher than 100K or above. And there's another form called lymphomatous form, which is the form we think this patient has, which usually causes lymphadenopathy without circulating blood involvement, but more commonly to have CNS involvement. So to diagnose this condition, a very important diagnostic tool is peripheral blood smears and bone marrow biopsy to see if there's typical tumor cells, because it has a very typical characteristic appearance of the tumor cells. So let me share my screen. So that's what we found this is not the picture of the patient, but this is what I got from UpToDate. But in adult T-cell leukemia, you can see this bizarre shape of the nucleus circulating in the peripheral bloods, or in the lesions in lymph nodes or bone marrows. So because of these appearance, we also often call that flower cells. And because its characteristics is also very rare of these conditions, often it needs hematology specialists to identify this, and it's commonly missed by other doctors, maybe initially check the specimens. Yeah. So that's what we got. And yeah, I think amazing discussion, and really happy to share this with all of you.
Wow, incredible, Ethan. Thank you very much for bringing that. I think we don't really focus much attention on maybe HTLV1, but I think this case definitely I will take away a lot. I will go read and learn and prepare an illness script, maybe get together with Maddie and
Yeah,
come up with, I know you like to make
do
notes
it.
and things, so that's how you learn, right?
Yeah.
You are exposed to something and you're like, wow, okay, I gotta make an illness script or something to remember and reference. But thank you for I know this was a painstaking process putting all of these fine details together. You've done a fabulous job, Ethan. Such a wonderful presentation. And also, Maddie, great discussion. Incredible how much of a rich discussion you were able to get out of this in the initial aliquots. So it just reflects on how much you've grown.
No, it was so enjoyable to discuss alongside you, Ravi. I learned a ton discussing with you, and Ethan, just a huge shout out to you. This is really, I can't imagine how much time you put into preparing this case and reflecting on it. And I'm so excited to learn more about HTLV1 and adult T cell lymphoma. Are there any other reflections you wanted to share in terms of what it was like caring for this patient or things that you learned?
Actually met this patient in hematology ward. He
Mm.
also met for intrathecal chemotherapies. And I found the presentation, the constellation of symptoms in neurologies and hematology very interesting. So I went back to talk to the teams and really collected all these diagnostic process. Yeah. Also another thing I missed is the hepatic involvements. So actually the tumor cells had a lot of variance. So even sometimes you could have a normal appearing lymphocytes that could be leukemic cells. So in retrospect, we did a repeat liver biopsies, but didn't show the characteristic tumor cells. But in retrospect, we think maybe there's tumor involvement in the liver as well because of infiltration into the reticuloendothelial system. Yeah, that's another point I think I want to share. Yeah. So overall, yeah.
So were you thinking that the severe elevation in liver enzymes was from infiltration in the liver or from kind of like these viral
Yeah,
infections?
we think the HHV6 is a red herring because just as Mark mentioned in the chat, it could be falsely positive in many conditions.
Mhm.
Yeah. Eventually we stopped the ganciclovars. And
Mhm.
yeah. Also, we cannot rule out drug-induced liver injury as well, as you discussed. Yeah, but we think maybe there's tumor invasion into the liver as well. Yeah.
Interesting. Wow. And then I'll have to read more, but it sounds like the HTLV1 chronic infection is what led to or predisposed to the lymphoma. Is that right?
Yeah, basically, in this condition, all patients has HTLV1 positivity.
Okay. Got it. Wow. Thank you so much, Ethan. I'm really excited to learn more about this. But I know we are at time, so I will pass the mic to Lyra for teaching points.
Yep. Thanks, Ethan, for such a great case. And thank you, Dr. Ravi and Maddy, for such an amazing discussion. So we started off with our approach to neuro problem, which equals time course times localization. And for the last one, we kind of built the path to localization. Motor concerned clue us that the lesion can be anywhere from the cortex to the muscles, but the presence of sensory component make muscle and NMD lesions less likely, so we were focused more on the peripheral nerve, spinal cord, and also didn't exclude the possibility of multiple lesions. Dysphagia and coarseness clue us toward the cranial nerves involvement, and the absence of bladder issues and also diminished reflexes on physical exam make us prioritize peripheral nerve involvement over the spinal cord. So then we talked about initial differential diagnosis, which can be brought in this case from nutritional deficiency to vascular problems and substance use disorders. So in order to narrow it down, we needed to know the past medical history and also the patient's baseline. And also we talked about the influence of recent hospitalization history on our DDX. And we talked about this can be a complication of surgery, or it can be truly unrelated problem. So we learned that cholecystectomy operation can be involved in presence of residual stone in common bile duct. Also cholangitis, Guillain-Barré syndrome can be triggered, and also we can be dealing with side effects of used medications during the surgery. Then we talked about our approach to peripheral nervous system involvement. We talked about the foot drop, which most common cause for which is peroneal nerve injury, but the combination of up and downstream symptoms make us consider multisystemic disorders like diabetes or alcohol use disorder. And also we talked about other possible etiologies like demyelinating disease, nutritional deficiencies, multiple sclerosis, ALS, amyloidosis. And in order to narrow it down, we needed to do EMG, nerve conduction studies, and lumbar puncture. Then we talked about severe acute liver injury, that we need to be sure that the enzymes are coming from the liver itself, not from the muscles. And we needed to check the AMS and ENR to differentiate liver injury from liver failure, because it can influence our management. Then we talked about differential diagnosis for liver injury, which combines into the scheme of two P's, which stands for plumbing and parenchyma. And plumbing can be represented by both bile ducts and vessels. Then we talked about testing that we got and multiple viral positivity. We talked about HHV6 that can cause rosolan phantom, hepatitis, fever of unknown origin. And we thought that it can be false positive, but in the setting of candidal esophagitis, we also thought about ongoing immunosuppression, and we found a cause for it, which was HTL1 virus and disease induced by it. And we learned about main manifestations, which was HIV-like action, leukemia, lymphoma, and MS-like presentation. And that's it.
Wow, Lyra, that was absolutely incredible. I feel like this case covered so many different topics, so I'm amazed by how well you summarized that and organized it. That is not an easy task, so huge round of applause to you for those amazing teaching points. Ravi, that was so much fun. I feel like we really get our practice in on neuro when we discuss together, so it's great. But really enjoyed this hour to co-discussing with you, Ravi. And yeah, Ethan, absolutely phenomenal case. I can't wait to read more about it. And thank you for presenting. I know that this probably took so much time and reflection, so thank you so much. And thank you, Julia and Lyra. So nice to see you all.
Thank you, everybody. Happy Tuesday. Take care.
Bye.
Bye.